metabolic acidosis also contributes to that. That comes from lactic acidosis, from lactate being released. That also comes from the disruption of the transport mechanism of sodium-potassium pump, and the potassium will be outside of the cell giving metabolic acidosis. Okay? So rapid recognition is the key, right? So normally how the patient comes in shock, of course, if there's no tissue hyperperfusion, they have cool, clammy skin, you know that. Majority of the patients will come in with hypotension and tachycardia, but why is that not reliable? Because you could be in distributed shock, which is septic and anaphylactic or neurogenic, and you're hypotensive, but you would not have tachycardia, right? Yes? Okay. So, in addition to that, I mean, actually the better indicator for us is to either do the index or to measure the urine output. Remember that having oliguria is one of the first initial stages of any type of hypovolemia and hypotensive state due to the deviation of the volume to the organs that are more important, right? Now, we also measure, as we mentioned, lactate as one of the indicators of shock and also prognosis. So if we look here, we have a lot of diagrams and algorithms. If you're thinking about one of the type of shock, which is hypovolemic shock, tell me what disease stages can give you hypovolemia? Dehydration, right? Anemias, your GI vomiting and having diarrhea, you're profusely sweating, you're bleeding. So those are examples of hypovolemic state that can give you hypovolemic shock, right? Mostly in patients that either because of lack of insurance or because they don't have any family that can bring them to the hospital or because they just don't want to come to the ER, they might think that they will improve, they come late in stages, right? So again, patients would have hypotension, cold and clammy skin, hypovolemic shock. You will always have tachycardia because there's vasoconstriction due to release of catecholamines. Now, all of them, that's the reason why they're here in the middle, they go through the process of capillary permeability and therefore edema, which the edema can be present as pulmonary edema, right? Or it could be present as peripheral edema in the lower extremities or as ascites because there's a third space extravasation as well. Remember that patients in later stages, due to the platelet migration and also due to the vicious cycle of activation of coagulation cascade, they can go through thrombosis. So all the patients in shock must be in DVT prophylaxis unless it's hemorrhagic, right? You're not going to put the patient on Lovenox or heparin sub-Q when they have hemorrhagic shock, right? But at least decompressive devices, right? Myocardial, which is cardiogenic shock. What can give you cardiogenic? Yes.
But like for example, in case of an hemorrhagic shock, you're bleeding, but you can, because of the hypovolemia, you can go into the DIC. So how you should do it? If you cannot give antibiotics because they're bleeding out.
Remember that, first of all, you need to see the source. I mean, if you're bleeding internally, you're going to take the patient to surgery and 24 exploratory, you try to contain, try to find the cause of whatever is bleeding, and after that, you could, 24 hours later, yes, you could put the patient in heparin drip. But again, remember, it's a controversy still, okay? Nobody has agreed exactly, yes, you have to put the patient on heparin drip, okay? But at least DVT prophylaxis 24 hours after, once you're able to contain the source of bleeding, okay? The same as if it's hematemesis, taking the patient to the EGD and do sclerotherapy and or banding or whatever, okay? So, cardiogenic shock, either due to the pump as a failure, and I want you to understand that, okay? Pump failure. The problem here is not fluid loss. The problem here is not hypovolemia, okay? Either you have heart failure, or you have cardiac arrhythmias, or you have valvulopathies or cardiomyopathies that are putting this patient into shock, okay? I understand that the cardiac output will be affected, okay? And if you think, which is the proper thinking, but I want you to also look at, again, I don't have it. I was leaving in my office.
I have a bunch because my markers are really close to like words that work.
Okay, so if you have a cardiogenic shock, you are assuming, which is appropriate, that if you're not squeezing properly, of course a strong volume and cardiac output will be decreased, right? Mostly if it's ischemic cardiomyopathy, right? Mostly if it's systolic heart failure, mostly if it's a valvulopathy related to aortic stenosis or regurg. Yes or no? But even though you might think, well, what comes out should go back in, it doesn't really apply for cardiogenic shock. What happens is that, yes, you might have, let's see, for example, 40% of cardiac output, right? That 40% of cardiac output is trying to come in as preload in the next cycle. But what's going to happen to the heart trying to relax properly and receive that amount of volume? Think about a boggy heart, right? So if you have a boggy heart, which it happens mostly in systolic heart failure, the fluid accumulates here, okay? And it doesn't go in properly. So therefore, listen, when you put a catheter, which in the past was the pulmonary catheter to measure the watch pressure, CVV, etc., now we do it through a central venous line, and we do it through Leal, which is still can measure cardiac output index and all that. If you put a catheter right here, fluid being backed up and backed up and backed up,
includes the peripheral recipient too, so the heart cannot pump out either.
how do you think that catheter is going to interpret
High.
venous return and preload?
Elevate.
Elevate. Let me, well, I'm gonna keep explaining anyways, because this PowerPoint is a little bit more extensive. So I want you to understand that normally, for example, the most common type of shock, which is hypovolemic shock, since you don't have enough volume going into the right atrium, the preload central venous pressure, which is the same thing, or venous return, which is the same thing, will be low. And that low volume is what's affecting the cardiac output and stroke volume. Do you understand? But the heart is healthy enough to keep relaxing and contracting, right? Now, the difference with cardiogenic shock, why the preload is increased, why the CVP is increased intravenous pressure or venous return, is because even though the cardiac output is compromised, is decreased due to pump failure, that same cause is impeding relaxation of the atrium and ventricles on the right side, receiving the volume. And that's the reason the volume backs up in the next cycle and in the next cycle. And when you put a catheter in your IJ, it's engorged. Because if I have a backup of volume, where's it going to? To my superior vena cava and to my inferior vena cava, right? So if I put a catheter in my internal jugular or subclavian, it's going to be interpreted as increased, even though you know it is not. Do you understand?
It's increased in that area.
It is increased in the area, but it's actually not increased in the tissue because the tissue continues to receive a low perfusion.
So it's like a false negative?
Correct.
Yeah.
But your answer for your exam and exit and board examination is like that.
And the preload
Increased preload for cardiogenic shock. And if you actually measure the pressure at the level of the pulmonary artery, which is an indirect pressure of biventricular and diastolic volume, which is your wedge pressure, will also be increased. And that's what distinguishes hypovolemic shock from cardiogenic shock, because the rest of the parameters are the same. Okay?
The CVP is the only difference.
And wedge.
Only one.
Okay, but we don't do wedge pressure. Well, some cardiothoracic surgeons still do it. That's old fashioned. So again, that's the causes of cardiogenic shock. Neurogenic shock, anaphylactic, or sepsis, remember those three belong to what's called distributed shock, okay? And what happens is that, remember, yes, they do have hypotension, and the reason why they do have hypotension, sepsis, number one, the amount of inflammatory mediators that are released, again, what did I make you memorize in Pablo? Vasodilation, and if you have vasodilation, your blood pressure drops, right? Capillary permeability, they also have edema, and they also have diabetes, right? Neurogenic shock, again, because of loss of sympathetic response, they also have vasodilation, and anaphylactic shock due to release of histamine, due to mastocyte degranulation, right? But the end result is exactly the same. Yes.
Do you have a septal
Oh, by the
defect?
way, I left your preceptor ribbons signed in my office. I forgot to bring it.
Stop. So if you have a septal defect, it can cause a low cardiac output. Will it give you the same exact kind of cyst? Because,
If you go into shock,
but even if you don't go into shock, it'll produce kind of like an increased venous return, right? On
if you
insertion.
have with some of this defect, ventricular, or
Right, ventricular.
intraventricular.
Right.
Okay, if you have an intraventricular defect, remember that the blood comes from the right atrium to the right ventricle, right? And it's supposed to pass to the pulmonary, but some of the non-oxygenated blood goes into the left ventricle, right? And it gets mixed. So, oxygen-wise, again, this is more common in pediatric patients, even though, I mean, it could happen in adults. Oxygen-wise, the patient doesn't get affected as much. This is a non-cyanotic type of either congenital or acquired defect. But yeah, of course, the volume here increases, okay? And if the volume increases here, actually the cardiac output is not affected unless the high pressure will create an additional aortic stenosis. But if the pressure increases here because there's a communication still, yes, of course, blood can come here, like maybe 20% of it, and in the next cycle accumulate, and eventually, yes, the patients can have the same hemodynamics.
Hypertrophy of the.
And hypertrophy of, biventricular, but left ventricular hypertrophy first. So if the left ventricular hypertrophy happens because of increased pressure of the communication, then of course patients can have aortic stenosis and therefore decreased cardiac output and all that.
Right.
But those are later stages. All right? So this is how to evaluate a patient with shock, okay? So, for example, it makes sense that if you have a patient with history of trauma, patient coming in with a motor vehicle accident or ground level fall, or just because you were biking and you were hit by a car or something like that, you are thinking about the most common etiologies that can provoke shock. Number one, bleeding. Either externally that you can see because of an amputation of a leg, right? Or because you have internal bleeding in the abdomen, for example, or in the chest cavity, all right? So if you do have, for example, a motor vehicle accident, all the disease process can also happen that can give you another type of shock, which is called obstructive shock. When you have a motor vehicle accident, even though this could also happen spontaneously, okay, to any patient that has a bulla or whatever. If you have a motor vehicle accident and you have a chest trauma and a lung contusion, what's gonna happen to your ribs? Fracture, right? And if you have a rib fracture, that rib can puncture the pleura, right? And the patients can have a pneumothorax. Depending on the degree of pneumothorax, can actually affect the mediastinum, right? So, remember that the heart is in the middle of your chest, and if you have a lung that is completely collapsed, pushing away, right? Compressing the heart, think about this heart being all compressed due to positive pressure intrathoracic. So that heart cannot expand properly, right? So therefore, if you cannot expand, that means you cannot relax, right, to receive the blood as preload, right? So therefore, your central venous pressure and cardiac output will be decreased, right? This can be a traumatic tension pneumothorax, or the same thing happens in a spontaneous rupture of a bulla in a patient with COPD, emphysema, having also tension pneumothorax, okay? So tension pneumothorax, traumatic or not, or iatrogenic after thoracentesis, can give you obstructive shock. And why in the past was included in the cardiogenic etiology? Because in reality, the patients die because it's compressing the heart. It's not allowing the heart to relax and receive a proper preload, and therefore not proper cardiac output. How do you think the patient is trying to compensate? Tachycardia, right? Vasoconstriction and tachycardia to be able to bring more blood. So what's gonna happen to your heart rate? Increased. What's gonna happen to your SVR? Increased. Of course.
So the cardiac tamponade can be.
Wait, yes, that's another one. That's tension pneumothorax, right? Now, of course, there's always stages of shock. And you're gonna listen to this, but you're not gonna digest it, because otherwise you're gonna be confused by answering. What do you think is gonna happen if the lung continues to press and press and press and press before the patient goes into cardiac arrest? They're gonna not tamponade itself because there's no fluid outside, but since there's so much compression and the preload cannot come in, it's gonna also back up, right? And engorge the superior vena cava and inferior vena cava. And if you ever put, which we don't never do it for tension pneumo, if you ever put a central catheter, you're gonna also see that in later stages of tension pneumothorax, you're gonna have an increased CVP, even though the cardiac output is decreased. Do you understand? Now, patient with pericarditis and pericardial effusion continues to accumulate to the point of a cardiac tamponade. I want you to see the fluid surrounding the heart as an interface impeding volume going into the right atrium, right? Or ventricle. So if you have a barrier in here, if you have a fence or an iron door behind that, how difficult for you is to bypass the main door, right? You have to apply double force. So therefore, even though there is a percentage of volume that goes in, otherwise the patient will suddenly have a cardiac arrest and die, right? Even though there is penetration of volume into the right atrium, is compromised greatly, right? So therefore, again, fluid backs up, and if you put a catheter in cardiac tamponade, your CVT will be increased. Do you understand? That's the reason why tension pneumothorax, cardiac tamponade were included in the past as cardiogenic shock because they have the same hemodynamic.
But the heart rate is gonna go low.
Yes, no, low. The heart rate is gonna go high, of course. Your body says, I don't have enough volume. I don't have enough cardiac output. Let me increase, right, the contraction, even though they can't contract, let me increase the contraction to be able to compensate, right? So, you have trauma, again, do you have a hemorrhagic shock? Do you have a chest wall contusion to the point that can give you either, what type of effusions do you know? Cirrhosis, empyema, what about the hemorrhage? Hemothorax. So you can have a hemothorax, and that's the reason why the patient's in shock. What will you do there? Well, you would see it in a chest x-ray with a large effusion in a patient that was normal and had a motor vehicle accident. Most likely that is blood, right? So you're gonna take the patient, if the patient's hemodynamic is stable, which we're not even talking about that because the class today is shock, what are you gonna do with that patient? Not only a thoracentesis and drainage, you're gonna take that patient for video-assisted thoracoscopy and see what's going on, right? Because if you put a chest, yeah, of course you're gonna put a chest tube, but if you put a chest tube and it keeps draining and draining and draining, that patient has to go to the OR, right? If there is also chest contusion and you see that in a chest x-ray, you have rib fractures, of course you're gonna think about what? Again, pneumothorax, tension pneumothorax. I don't know if you have seen a trauma patient that they actually do scans from head to toe. Everything, at least in Kendall region as a trauma level 1, the patients come in, they don't even bother doing x-rays. Just CT brain, CT neck, CT chest, CT abdomen, CT pelvis. Everything is CT. And if they see the legs destroyed, CT of the legs. So CT of everything. Why? Because they're looking not only for, again, hemorrhagic sources, but they're looking for tension pneumothorax to see if there's a heart injury that can give you tamponade. If the patient is arresting upon arrival, you have to rule out everything. And basically, I mean, sometimes they go far and beyond without having the actual result or doing a proper assessment. They put a chest tube, they go, the patients in CPR, and they do actually pericardiocentesis because they're ruling out every single possible cause of shock. Okay? Now, there's no history of trauma. Maybe why the patients have hypovolemic shock? Is it because you're vomiting, you're having diarrhea? Look at the history of the patient. Or is it because it's hematemesis or melena? Or other causes of hypovolemia that we have gone through, right? Dehydration, profusive sweating, depending on the scenario, depending on the history of that patient. And if it's so, basically what you have to do again, 30 mLs per kilo, right? Resuscitation, and then continue fluids. Now, if you have given already your bottles of 30 mLs per kilo and you see that the patient is not improving shock-wise, of course you're gonna put the patient on vasopressors, but you have to think about the possibility of occult bleeding, like internally, for example. You can do a CT scan of the abdomen, you see the belly distending. So depending on your assessment, and also you can do type and cross and either transfuse the patient if there's hemodynamic instability and you're suspecting bleeding from another source, okay? Patient has fever, hyperthermia, hypothermia, markers of systemic inflammatory response or sepsis. You must think about septic shock, right? And not only you're gonna, yes, called sepsis and do the lactic acid, but you're gonna also do the 30 mL per kilo volume resuscitation and put the patient on broad spectrum antibiotic, which you know that is a either third generation cephalosporin or fourth with vancomycin. Sometimes you can add an aminoglycoside. It really depends on the immunostatus of the patient, right? If it's immunocompromised or not, if it's coming from a nursing home, we already have talked about that, right? You have a patient with, for example, an EKG that has signs of ischemia. What is that? Acute coronary syndrome. You're going to treat the patient as an acute coronary syndrome the same way, right? You're going to give the patient either TPA if it's not in a cath lab facility, right? You're going to give the aspirin. You're going to put the patient on heparin, bring the patient to cath lab for percutaneous coronary intervention. Or if not, TPA and then transfer exactly the same way. That would be a cardiogenic shock type. If you see, for example, a patient with cardiac arrhythmias and the patient is in shock, yes, you're going to treat the underlying cardiac arrhythmia. For example, you have a patient on SVT, remember the ACLS protocol, that is not perfusing. What do you give? Okay, you have a patient with a supraventricular tachycardia with low blood pressure.
No, you have to do
Diversion. That's symptomatic. That's symptomatic. Yeah, of course we always give fluids.
Yeah, but no.
Always give fluids. Because through any type of ACLS protocol, remember you have to think about your H's and your T's, right? And one of the H's is hypovolemia. So every time you're called to a patient that is either rapid response or whatever you call it in your hospital, or go rescue, whatever, you must give fluids because it's a part of an H, right? You put oxygen or you do not, your ABG is your H's and your T's, right? But for that particular patient, since it's hemodynamically unstable, you must do cardioversion. Otherwise, if it's stable, adenosine, and you follow the protocol, right? So, having any type of cardiac arrhythmias, having a history of heart failure with a prior echocardiogram, either systolic heart failure or with severe hypokinesis, which is what type of heart failure? Diastolic, right? Or any type of valvulopathy that is putting the patient in shock. Of course, it's obvious that it's cardiogenic shock, so you have to treat the underlying problem, right? You have instead hypotension and bradycardia. Either, remember that, if you have a history of traumatic brain injury, that's obvious, right? Or a trauma patient, obvious. Stroke, obvious. That is what? Neurogenic shock. Or Guillain-Barré, or myasthenia gravis, crisis, etc. That is obvious that is neurogenic shock. What else can cause a type of distributed shock that is not included in anaphylactic, neurogenic, or septic? Is your patient, for example, with digoxin, and is digoxin toxic, for example? Or is the patient hypothyroid? You know that we received a patient the other day? It wasn't because I'm right or anything like that, no. You know that when a patient comes with altered mental status, okay, and or hypotensive, part of the protocol is to do not only your CBC, your CMP, in this case she was altered mental status, all the stroke protocol, we should do the CT brain, the MRI, MRA, or CTA, right? Everything was normal. She was intubated because she couldn't maintain her weight because they were thinking about stroke. But normally the protocol is to do the CBC, your CMP, your TSH, your hemoglobin A1C, your lipid profile. It's part of the protocol. It's not that I'm brighter than anybody else. The TSH comes back 41. Of course, the next step is to do T3, T4, right? The next step is to do T3, T4. What do you think I did? Before that, I went to the room and the daughter was at the bedside. She was still intubated, and I asked her, "Does she have any history of hypothyroidism?" She's like, "Actually, yes. I mean, 10 years ago, This lady lived in Argentina, and she was using Synthroid, but she was losing so much weight. Listen to this. She was losing so much weight, the daughter. She was losing so much weight that she just stopped taking it. How long did she stop taking it? I'm like, well, we have been here in this country already 6 years. Maybe about the same time. I'm like, how much Synthroid was she taking? Well, I don't remember, but it was a very high dose. What do you think I did? I know that I ordered T3 and T4, but I put her on Synthroid IV right away. What do you think she was having? What was she on mental status? Edema, coma. She was hypotensive. No, she was hypothermic, hypotensive, bradycardic. No, I mean the value was released at that time.
Oh.
I happened to be the nurse. No. She came the night before, and that's part of the orders that we normally put in, right? She already had the results for the CT brain, MRI, blah, 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 and the CBC and all that, but the DSH was pending. And during my shift, in the morning, but a little later, I saw the value. And I panicked when I saw that. So, of course, that was the reason why she was not only out of mental status, and she lost her airway, but also she was in a state of shock due to mixed edema.
When you lose weight, it's supposed to be hyper?
Yeah, but they should have regulated the
She was having the symptoms.
Remember that remember that when you have hypothyroidism and you're overtreated, you can go hyper, right? And apparently this patient, by the way the doctors explained it, she just discontinued because she lost weight. I don't even think she got any type of professional guidance or advice. She did it on her own, and that's it. Okay? So, consider the thyroid function test as well. Or, for example, Addisonian crisis that patients have, remember, lack of what? Cortisol or mineralocorticoid, right? Remember, instead of having hypertension or normal blood pressure, they have hypotension, right? Remember that instead of having retention of certain water, they excrete certain water, so they go into a hypovolemic state. Instead of having hypokalemia, they have hyperkalemia. They go into metabolic acidosis, the same signs of shock, right? Now, let me talk about, which I skipped and I just saw it, pulmonary embolism. Part of the obstructive shock, which also in the past was included as cardiogenic. Remember that when we talked about pulmonary embolism, we talked about massive versus submassive, right? Pulmonary embolism. And the difference is that in the submassive pulmonary embolism, you have what?
You don't have
ventricular straining. And how do I see that? Remember, you have to have an echo. You have to have an echo. So you do an echocardiogram, and what do you see?
Sometimes I see the CT of the chest.
That implies, because there's an engorgement of the pulmonary artery, but actually how you diagnose it is by echo.
You're not gonna have a decrease of the CHF, yeah.
No, exactly.
No, yeah, that's what you asked. Without systemic hypotension.
Yeah, we're talking about the difference first. So, ventricular straining, that in an echocardiogram, what you see is right ventricular dilation, right? Sometimes it goes so high that it's atrial as well, dilation, on the right side, of course. And also your right ventricular systolic pressure, which is your pulmonary artery pressure, is increased more than 30. It's considered more than 30 millimeters of mercury, even though 15 to 30 is the normal value, okay? So, in addition to that, When you have ventricular straining, what else can you release? Troponin. When you have ventricular straining, what else do you release? Stretching of the ventricles, BNP. Right? But the patient is hemodynamic stable. So that means that submassive pulmonary embolism does not classify as a type of obstructive shock because shock is hemodynamic instability, right? So that means that the massive PE is everything that I mentioned plus hemodynamic instability. And that hemodynamic instability can be from hypotension up to cardiac arrest. Yes? So if a patient has a massive pulmonary embolism, is it your pulmonary artery going to the lung? Having a PE increases, right? We already said it, right? The pulmonary pressure. And if the pulmonary pressure is increased, the volume is going to back up, right? And the volume backs up in the right ventricle. That's the reason why it's dilated. That's the reason why we say ventricular strain. So if we have right ventricular dilation, first of all, the tricuspid valve will fail, and the patient would have tricuspid regurgitation, and therefore what? Right atrium pressures increase and dilation as well. That's why I said depending on the severity. And if I have right atrial pressure, do you think that if the blood comes into the right atrium, it's going to enter properly? No. It's also going to back up. And if you put a central venous catheter there, it's going to increase as CVP high, preload high. That's the reason why it's, again, it is in the, it used to be the classification of cardiogenic shock. Anything, guys, in other words, that increases the intrathoracic pressure by a tension pneumo, massive PE, or cardiac tamponade impedes preload and therefore volume backs up, increasing the reading of a central venous pressure to be high.
That's the only reason. Because if you have an increase of the central venous pressure, your preload technically is decreased because you're not having the blood. And the preload is the blood coming into the atrium, so the preload is decreased.
As well. But you could interpret that as the pressure doesn't allow it to enter, or the amount of fluid in the interface for cardiac tamponade does not allow it to enter.
But technically the preload is decreased.
In reality, it's decreased.
I'm not gonna say
Because you will
it's
never,
decreased.
you have to say it, that it's increased. Why? Because if you put a catheter in the machine, either Leal or pulmonary wedge pressure catheter, it's not gonna read low, it's gonna read high.
But what I'm reading
Even
is
though
the
you know
pressure-
the tissue has decreased perfusion due to decreased preload.
But what I'm reading is the pressure, not the actual preload.
Well, what you read is CVP, cardiac output, cardiac index, stroke volume.
But I'm not reading the preload technically.
Now, let me ask you a question.
I'll give you some time to charge.
Let me ask you a question. Treatment-wise, as well as contradicting. And you must answer as such, because remember, theoretical answers is where you're going to be tested, unfortunately. What happens in a patient that has a tamponade? You have fluid outside, right, the heart. It's not allowing fluid to go in, right? Therefore, there's tissue hyperperfusion. I understand that the first line of treatment is pericardial centesis or window, right? To take out that fluid, take out that interface, and allow fluid to go in. But while you're preparing the patient for the OR, what are you gonna do? You have to give fluid.
Fluid resuscitation.
You have to give fluid resuscitation. Guess what? In board examination, they said that fluids is not a treatment for cardiogenic shock. Because hypovolemia is not the etiology, it's pump failure.
The butyramine.
That's what I'm thinking.
Right?
But in clinical practice, we have to give fluids.
Yeah. Okay.
We have to.
But pretty much.
Even if in a PE, you do thrombectomy, and you even do TPA for massive PE, which we have done in very young patients, or you put the patient on heparin, but meanwhile, what do you have to do to improve the preload of that patient? You have to give, but you have to give fluids. Yes, you're gonna put the patient on dobutamine, or Primacor, or Inocor, but you have to give fluids in clinical practice. But in the test, cardiogenic shock does not require fluid resuscitation because it's a pump failure. And you must answer dobutamine. Ionotropes. Do you understand?
But in clinical practice, you're putting that patient in third spacing, overload, pulmonary edema.
If it's related to heart failure, it's different. Because if you have a patient in cardiogenic shock,
But still, cardiogenic shock, you're not pumping, so you're not really circulating that blood.
okay, but how do you think I'm gonna infuse the tissue in a tamponade? Maybe you have a normal, healthy heart that doesn't require squeezing action with dobutamine or Primacor. And I know, again, first line of treatment is to remove that fluid, right? Window, pericardiocentesis, stat. But meanwhile, what are you gonna do? You have a healthy heart, just because you had a pericarditis by a viral condition. If I squeeze you, you're not gonna do anything. And I know that fluid is gonna continue backing up and you're gonna have a lot of edema, but my major concern is hypoxia to the tissue. So you would see that in clinical practice. Fluid. You might put dobutamine just for the heck of it because it's a cardiogenic shock as well, while you prepare the patient for window or pericarditis. But if you answer fluids, they're gonna be wrong.
I wouldn't answer that.
Fluids and hypovolemic shock, right?
I'm just giving her for the pumping, so it's not gonna go anywhere.
So shock, guys, is one of your last lectures, despite images. But we're gonna do, since it's gonna be a group test, let's do comprehensive, really comprehensive. You need to remember pulmonary embolism treatment, right? And tamponade treatment and all that. All right. So, for example, patient comes with hypoxemia. Of course, it could be cardiogenic type of shock because if you have a cardiac arrhythmia, fast or slow, that can also affect the amount of blood going into the tissue, and therefore patients can have hypoxemia. Or if you have a severe anemia, or if you have bleeding, for example, massive bleeding, of course you're gonna have hypoxemia as well. But if the patient is not bleeding, the patient's volume status is normal, and the patient is hypoxemic, think about possible PE as well, okay? For example, you're resuscitating the patient, as I said, the patient's blood pressure doesn't improve, and you have a distended belly, you must do a CAT scan of that belly because maybe the source isn't there, okay? Wheezing, for example, patient with asthma, or patient went to a restaurant and ate seafood or peanuts or whatever, or lisinopril on board, and now the patient comes with angioedema or wheezing, anaphylactic shock. Okay, so we're gonna go through all the treatments. So this is what I basically said. I mean, you have to actually do the test related to the actual etiology of the patient. You do a chest x-ray again in a trauma patient, which we normally do CT, is to try to rule out the cause of the shock. Do I have a hemothorax? Do I have fractured ribs that is causing me a tension pneumo? Do I have a cardiogenic shock due to a cardiac injury giving me a tamponade? Okay? EKG, where you're going to do an EKG, basically, do you have, for example, ST depressions or elevation that you might think about acute coronary syndrome, like non-STEMI or measure STEMI, and you treat accordingly, right? or you have a type of arrhythmia that is impeding perfusion, like a super slow, rhythm, like bradyarrhythmias or tachyarrhythmias, and we have to treat based on ACLS protocol. Hypoglycemia patients with a 30, in the 30s, we had a patient the other day, completely in shock because had glucose of 30 at home. Okay, CBC, your hemoglobin, right? If you have a low hemoglobin, that can put the patient, of course, into not only hypoxemia, but also hypovolemic shock. Leukocytosis with fever and signs and symptoms of infection, septic shock, any electrolytes, like if you do CMP and you have elevation of urine creatinine, you have hypoconcentration, right? Dehydration state or GI bleed, etc. Look at your potassium, for example, that's a guidance for metabolic acidosis. You have to do your lactic acid, you have to do your ABG as well. And we have lots of interpretations of all that, all right? So again, management, guys, is basically depending on the underlying condition, right? So peripheral versus central. Now, really depends. I mean, you're gonna put large bore needles, at least 2, right? To start rapid resuscitation of either fluids or inotropes for that particular patient, right? But remember, if you need readings of your hemodynamics, you have to put a central line. Or if the fluid resuscitation, for example, does not improve the shock status of the patient, you must start vasopressor support, and you must insert an arterial line to measure blood pressure more accurately, and central line to give the vasopressors that cannot be given peripherally, okay? So we're gonna go through the hemodynamics. Basically, even though the CVP normal values are, depending on the book that you read, 0 to 6, 2 to 6, okay? We always try in hypovolemic shock patient to put the CVP at least a mean of 12. Mean of 12, okay? Also, in addition, think about intubation process. You as nurse practitioner, unfortunately, you didn't go through clinical procedures, but one of the contents that we used to teach clinical procedures was anesthesia, and what to give to patients during the process of intubation. Propofol, for example, is the cardiac depressor. So if you have a patient already in hypotension, you're not going to choose propofol, right? If you have a patient in cardiogenic shock, even less, you're going to choose propofol. Always try to choose a medication that can put the heart into less depressive state. And those are your ketamine, for example, your etomidate. If you have to sedate your patient, fentanyl is more appropriate than actually propofol. Okay? First, I mean, as a benzodiazepine.
But still decrease the blood pressure.
Okay? So,
what's the other medication that once you're intubate, you do accommodate, but instead of propofol, what's the other name?
The socks?
No,
but that's for like,
the drip.
Precedex.
When they're intubated. Precedence.
the Precedex is an anxiolytic.
That's not.
This is not for intubation process.
No, I mean the intubation. I mean, once you're intubated.
Oh, yeah.
you just-
Yeah, Precedex is less cardiodepressive as well. But that's after, that's to keep the patient, in reality, I mean, Precedex can actually knock you down if you're like a 1, okay? But like 0.5, 0.6, the patient's actually awake and they're interacting, even if they're intubated, it's actually to decrease the anxiety, it's an anxiolytic. Intubation process, remember these patients most of the time go into severe metabolic acidosis. Don't do what you showed me.
Yeah.
Last class, he showed me a case of a patient with a pH of
6.9.
6.9,
Yeah.
okay?
Lethargic, confused.
First,
and
GCS
under
less than 6.
1200.
Metabolic acidosis severe with 6. Of course the patient went into cardiac arrest. You must intubate this patient to decrease the breathing workload, okay? The patient is in severe metabolic acidosis. How do you think the patient is gonna be breathing? Right? It's a compensatory state. You have to be in respiratory alkalosis to be able to compensate. So the workup breathing is so fast to try to overcome the severe metabolic acidosis that the patient's gonna get tired and it's gonna be a vicious cycle. And that's the reason why a patient went into cardiac arrest. So please try to intubate as soon as possible. And again, you're gonna see that if the patient goes into ARDS, we already treated ARDS, right, with high positive pressures in the ventilator. Now, we already said that acidosis itself depresses the cardiac cells, right? Not only due to the entrapment of the calcium, but also the acidosis disrupts the entire Krebs cycle and produces tissue hypoxia, leading to depression of the cardiac output, right? So it's actually a negative ionotrope on itself, okay? So try to correct it as soon as possible. Now, we already have talked about use of bicarbonate, that even though the guideline says no over 7.2, so you have to start thinking about giving sodium bicarbonate when the pH is less than 7.2. Again, don't wait too much. That's detrimental for the cell and the patient as well. And we already just said, I mean, your metabolic acidosis, the patient is always in hyperventilation state to be able to compensate. Now, we also, this is rare, okay, that I used it the other day, rare. Okay, sometimes when the patient's metabolic acidosis is so severe that the patient is even in sodium bicarbonate drip, we help with tranexamic acid, which is called TAM or TRIS, okay, it's for severe metabolic acidosis, super expensive. Again, think about anemias as well. Severe anemias can put the patient into hypoxic and hypovolemic shock. Why? You know that the hemoglobin carries the oxygen molecule, right? And that's the reason why. If you have a hemoglobin less than 5, of course you're going to be not only in shock, but also in hypoxemia. In addition, anemia itself produces a hemoconcentration, right? And that also increases the viscosity of the blood, increasing the risk for thrombosis. So, what are your goals? This is very general, and then we're going to go through the hemodynamics. What are your goals? Actually, in hypovolemic shock, to be able to increase the preload, right? Therefore, increasing cardiac output and increasing tissue perfusion, right? Which, remember, CVP or wedge pressure, which is the amount of pressure in the pulmonary artery, is an indirect measure of the ventricular and diastolic volume, okay? Follow your lactate, okay? Because it's a prognostic factor, not only of mortality, but also of treatment success, all right? This is something new. You can also measure again, this is a research study. I haven't even seen it, okay? It's a GI tonometry. Basically, you put a balloon in the stomach of the patient just to measure the pH. They used to do it a lot for patients who have GERD, okay? And now they're thinking in research studies to start doing it for patients with severe metabolic acidosis to know the source. Yes? Of course, go. Go.
Only me?
Where you going?
Thank you.
Okay, come back in 15 minutes.